कोई दिक्कत तुम्हें तो नहीं है? मुझे तो है।
वो लाइव हो गया है। ओके,
हम लाइव हैं।
हाँ लाइव है।
Are we live?
ये तक लाइव।
Hira, please confirm.
अब तक लाइव हो।
स्टार्ट कर सकते हैं।
जी सर।
Okay, so hi, good evening everyone. We are a little bit late in starting of this session because of certain YouTube issues. So now we are live and I think we are good to go. So okay. Okay, so I think we are ready to start. So basically the topic chosen for the day is the management of the COVID patient. And everybody might be wondering why a orthopedic surgeon has been chosen for such a topic. No, the management for COVID-19. Now, why I am taking this particular topic, there are two reasons for this. Okay, there are two reasons. First of all, we are managing a COVID-19 center as of now in this COVID second wave that we had in the year 2021. So we are managing a COVID center, and definitely the second reason is because my MBBS degree is 5 years senior to my PG degree. Okay, so on the basis of that MBBS knowledge that I all gained in those 5 years, 5.5 years, we have been able to successfully run a COVID center. And obviously with the help of the rest of the team, we have done pretty well, and the patients have gone home in a good situation, good condition. So that is the only reason. So we have planned in DBMCI almost everything about the COVID-19 scenario, and you know that most of our faculties, they were down with COVID-19, but still we are coming back on track, and very soon the whole team will be ready to present good things in front of you. So basically, when you talk about the COVID-19, there are lot many questions which are still unanswered. And by this time, almost after 1.5 years of the pandemic started in India, we started with the lockdown on 22nd of March 2020. So after that, at pan India level, we had this lockdown. We were trying to control the disease and so on. So I suppose by this time, every medico is aware of the basic management plan of the COVID-19, right? AIMS has been releasing guidelines again and again, and we have been following them, and following the guidelines, we have been able to see that results were good. So there is nothing new that I am going to tell you in regard to management, but yes, certain things which we need to keep in mind while we talk about the management plan for COVID-19. Yes, definitely, I would like to discuss with you that. So when you talk about the management of COVID-19, basically any management, it simply means that you have to discuss about how you reach to the diagnosis, the approaches, the investigations, and the treatment part, isn't it? The investigation as well as the treatment part. So broadly, there are two sections that we are going to discuss. Now, by this time, okay, so by this time, we all know that what all basic investigations we are getting done in the case of COVID-19. So COVID-19 is basically affecting our lungs. We know that very, very simply. And what all features we get. If I broadly just classify the COVID picture, now I'll not talk of anything bookish. I'll talk what we have been seeing practically in our clinical scenarios. Okay. So the clinical features that I have been able to see in the patients who have been doing well at home, who have been doing well in hospital, and then getting into severe form of the disease. See, basically, if I divide the COVID scenarios, it can be easily divided into three categories. One is an early phase where the patient basically gets flu-like symptoms, right? So if I divide the COVID in three phases, in the early phase, any of the COVID patient will start having some flu-like symptoms, some cough, some cold, running nose, like that. So these are flu-like symptoms, and majority of us, we have experienced that. So that can be seasonal also, that can be because of COVID also. This is what you call an early phase. Then in the second phase, basically the virus, the infection, the second phase, it enters the lungs. That is the stage where we see the development of pneumonia or the involvement of the lungs, right? So in the second phase, the infection, it involves the lungs, and if taken care well, it will not go into the next stage. Otherwise, it goes into the third stage, where what we see in the third phase, what we see, we are able to see that there will be a systemic involvement, right? Like multiple other organs will be involved. The lungs, they go into the ARDS, the hyperinflation syndromes, and then the multiple organ failures. This is the stage where the patient goes into ICUs, the patient goes in under ventilator, and then so these are the three phases. Now the flu-like symptoms, majority of the patients, they have experienced it in last 1 year, 1.5 years, and almost each one of us have been affected by it. When you say the second phase, see, this is very, very interesting. I know that many of the non-medical people will be watching this. So I can tell you one very interesting. See, everybody knows how the virus get into us. The virus gets into us via nose. No, it is very, very simple theory. So when it goes into nose, there are 2 or 3 areas where it can go and attack. So if the virus goes into the nose and it goes upwards, like towards your CNS, the central nervous system, the brain, what will happen? What will be the usual complaint of the patient? The usual complaint of the patient is the loss of smell, right? Now, what exactly is the reason for loss of smell? You might have seen so many people saying that I got COVID and I'm not having the sense of smell. I cannot smell anything. So this is the initial phase, the when the virus affects. So when the virus goes in, it can go to many places. So first place I'm telling you is it goes upwards. So when it go up, it causes a loss of smell. What is the reason? We don't know, but there are many studies being done why there is a loss of smell in the COVID scenario, the COVID infections. So the simple reason that has been given is that the olfactory cells, which are located in the upper nasal cavity, they are very, very vulnerable to this COVID-19. So olfactory cells, in simple language, we all know it simply means the cells which can sense, which have give you the sense of the smell. So these get affected, and because of that, we lose the smell. So if somebody is losing smell in the initial phase of the infection, it is pretty good. It has that simply means that the virus, instead of going down towards your lungs, it has gone up towards your brain. So there is less need to worry or less need to panic. You will be fine in some time. The recovery expected is very, very good. Okay. So the virus can go up. Now the virus can go down also. So when it goes down, we know that we have got 2 areas where it can go. One into your airways, one into your abdominal area, so esophagus or the larynx. So when it is going into the abdominal area, there are two tubings here. For the layman's, there are two tubings here in the throat, you can say. So when it goes into the abdomen area, it can produce your abdominal symptoms. So abdominal symptoms like you can have diarrheas, pain, abdomen, discomfort, and so on, which everybody might have seen in the patients of COVID. Third area where it can go is directly into the lung area. So when it goes into the lungs, it produces all your this second phase viremias, and then going into the third phase, that is ARDS, acute respiratory distress syndromes, and multiple organ failure, and so on. Right? This second phase that I just said, when it goes into the lungs, in this the patient has presented to us in two categories. One, the patient who needs oxygen, the patients who need oxygen, the O2, and the one basically I should write who doesn't need. Initial phase, they doesn't need oxygen, and second phase, the patient who need oxygen support. Right? And this is the most important phase basically, when you should be able to catch hold the patient, you should be able to hold the symptom in this phase only, where the patient requirement for the oxygen is not there. If it is not there, there are high chances that the patient might get into converted into a patient who is needing a oxygen support. Right? So when you have the initial symptoms, usually we say that it is around 3 to 5 days period that the patient might have involvement of the lungs. So if it is viruses going down into the lungs, it can take up to 3 days or 5 days, 3 to 5 days to affect your lungs. So this is broad, the clinical phase, how it affects. Now broadly, it has been seen in COVID picture that the 5 areas, the 5 common areas where you can see the features of COVID, the 5 common regions, they are the features of COVID can be seen in your eyes, they can be seen on the skin, they can be seen in the gastrointestinal area, as I said, the gastrointestinal tract or the GI areas, right? Like your diarrheas, constipation, and so on. The disease, the COVID-19, it can affect your liver. And then at last, obviously, the heart. These are 5 regions which have been commonly seen to get involved into the COVID-19 infection. Okay, so these eye features or the skin features will be very, very easily seen, will be seen in the initial stages only. When somebody gets the features of GI tract, the loose motion, the constipation, pain, abdomen, discomfort, all these things, all these 3 basically the patient will catch in the initial phase only. But when there is involvement of the liver or when the involvement of the heart starts, it takes time to tell you. Either the cardiac activity will be sudden to cause a collapse of the patient, or the liver or the heart might be getting affected, and the patient may be knowing it after a certain point of time. Right? These are 5 areas. So this is how basically the COVID's clinical scenario goes on, and these are the 5 important areas which are getting affected. Now broadly, if I tell in a layman language, everybody just simply feels like that the COVID situation is all about lungs, and we have to get investigation, we have to get admitted, and we have to get the treatment. It is not like that. I'll tell you something brief about the common investigations that we get done in cases of COVID infections. The basic investigations will not be stretching the session very, very long. You all know the basic scenarios, but I am telling you the basic importance and relevance of each and every point that we see in the COVID patients. Usually you might have seen that when you talk about a COVID patient, certain investigations you should get done in the initial phases only. When a patient presents to you with a flu-like symptom, the initial investigation that should always be done, one is a complete blood count. Complete blood count gives you information. What is the CBC? This complete blood count, how does it help? Number one, the TLC count, the total leukocyte count, which is usually increased in the cases of COVID-19. Right? The TLC count, which is usually increased in the cases of COVID-19. And second, in all the cases, we can see that the neutrophils may also be on rise. So in the initial complete blood count, the very, very basic investigation, if we see that there is a rise in neutrophil or there is a rise in TLC count, we can suspect some infection is going on. Right? This is a broad, simple information that we can fetch out from a very simple investigation. Other investigation that we say are specific for the COVID-19, they are not actually specific for COVID-19. The other investigations that we often do, the other investigation which is being advised by people to all the patient, we are advising to everybody, they are, number one is the CRP, the C-reactive proteins. The C-reactive proteins, right? Now this C-reactive protein is usually, very, very high, goes very high in many, many infections. So I have to tell you just one very simple thing, that let's name the investigation first, the CRPs. Then we got the interleukins, the interleukin 6 level. Number 4, we get the lactate, or just a minute. Okay, the D dimers, the serum ferritins, the D dimer, and number 5, the serum ferritin. This you might have seen that we are getting these tested in almost every patient. But initially, what is required is only here. These are not a diagnostic criteria for the COVID-19. No, these are not diagnostic criteria. Basically, all of these, whatever features we say, these are all, you can say, the indirect markers of inflammation or infection in the body, right? This CRP, it can be raised in any other condition of infection or inflammation in the body. For like, if I tell you the broader levels, what exactly the CRP it denotes. CRP is a C-reactive protein, and how this protein is liberated when any antigen in the body, like in this case, what is the antigen? Antigen is a foreign body, the infection which is coming from COVID-19, and when this antigen it attacks on our body tissues, the interleukins, the cytokines, they are liberated, right? So the cytokines, they are liberated by the tissues in response to any of the attack by a foreign body on the tissues. And when this antigen attack on this cytokines, what is liberated from the tissues? Liberated from the tissues is CRP. So it increase in the level of CRP, it simply tells us that the tissue damage is going high and high. It is more and more. Okay. So when you talk about the normal levels, okay, so when you talk about the normal levels of the CRP, usually when you see, it should be less than 1. In a normal patient, when you talk of a normal level of the CRP, it should be less than 1. When you have got a level which is almost 1 to 3, you can say, we say that broadly it is some low grade infection. But CRP also is an indicator of cardiac pathologies. So there is a high chance that the patient may get some cardiac problem, right? So CRP can be a marker of that also. Now, when you go more than 6, it is said that there is certain good focus of infection which is now trying to infect the body, right? It is certain low grade inflammation is less than 3, but when it goes till 6 or till 10, so it is some body infection is there, certainly some foci has already settled. A foci has already settled. When it goes, usually we see that in the cases of COVID scenarios, I'm telling you all the practical points. The book says, what the legend says we read in books, but now in the practical scenario, what we are seeing that usually more than 10, it is seen in the cases of majority of the COVID patients, right? It is the most important marker. CRP is the most important marker that should be used to just assess the recovery or the deterioration of the patient if you want to talk for one single test, that is CRP. Now, why is it that? I'll be talking to you about that also, right? When you say severe infection, it is more than 20 to 25, we say it is now a severe infection. And more than 100 values, it is basically a critical score of the CRP. So increase or decrease in the level of CRP, it simply means that the CRP levels are increasing or decreasing. It simply shows you that the prognosis of the disease, whether good or bad. Now, from where this CRP is coming? This CRP is basically, as I said, the antigen, the virus, it affected the lung tissues, right? So if you say the lungs are like this, so when the virus goes and it affects the lungs, when the virus goes and it attacks the lungs, so basically it is not attacking when the virus is attacking the lung, the cytokines, the interleukins, these cytokines means the cell protection in the body. These interleukins, what they do, they get activated and then they start eating the virus. These interleukins, they start attacking the virus. And when they attack the virus, they forget, these are very notorious, these cytokines. What are these? Multiple types of cytokines we have, like interleukin 1, like interleukin 6, like TNF alpha, tumor necrosis factor alpha. What are these? These are all cytokines. What they do, they attack any antigen that is trying to destroy our tissues. So when the virus is attacking the lungs, these cytokines, they get aggravated, they get activated, and they start attacking the virus. When they attack the virus, they are so notorious that they forgot that whom to attack actually. We should attack only the virus or the tissues also. So what these cytokines do, they start damaging the lung tissues also, right? And when the tissue is getting damaged, we just discussed, when the tissue gets damaged, what gets liberated? The CRP. So this is the significance, you can say, the relevance of the CRP to be getting why we should get it done. Now this basically the CRP from where it is coming. This CRP, it comes from interleukin 6, right? The interleukin 6, it is a what I said, the interleukin 6 produce what it does, it is a acute phase marker, and by activating the liver, this CRP will be secreted with the activation of interleukins only. Whenever the interleukin 6 it gets activated, what it does, it induces the hepatic synthesis of CRP, means it increases the production of CRP from the liver. So this IL-6, you will find that most of the time the interleukin 6 and the CRP, they are increased side by side. It may happen sometime that interleukin levels are high, but still the CRP starts getting gradually down. So interleukin via liver, basically what it does, it increases the synthesis of CRP. That is how interleukins, the cytokines, they have a role to play to increase the CRPs, right? This is how it happens. Now D-dimer and serum ferritin, you already know the relevance of this D-dimer. What is a D-dimer? You know that when the virus cells, the virus, the infection, the antigen, they start damaging the blood vessel wall. So if this is our blood vessel and they start damaging the blood vessel wall, what will happen? The blood clots will start forming and they will try to repair these. And when multiple clots will form, what will happen? The blood is flowing here. Multiple clots will form. What will happen? They will compromise the vascularity. They will compromise the blood flow. So that is a relevance of D-dimer, which tells you that how much is the clotting, significance, relevance, the clotting power in the blood which is flowing. So broadly, if I say, the people often ask me that in practical scenario, what you have often observed about the investigation part. So I always say that the CRP is the best marker that you can. LDH versus ferritin, which one is preferred in inflammation marker? And Shovik has asked me a question that in the COVID positive cases, the LDH or ferritin. So I'll tell you, Shovik, if you want to actually just see the inflammation marker, again, I'm repeating the same thing. Go with CRP and the interleukins rather than believing on the ferritin or the LDH level. I'll tell you the reason why. I'll tell you one simple reason why. Because I was also finding certain literatures in most of the patients that we have discharged, in what we have observed. In certain patients, I'll tell you one of the example of a 26-year-old boy that we discharged just a couple of days back, some 6-7 days back, and today he came for follow-up. So when we were discharging him, his TLC count was high, right? So what I just want to tell you, in that 26-year-old boy, what we find out, that the leukocyte count was high, TLC count was high, the leukocytes were raised, that was point 1. In that patient only, the level of, if I'm not wrong, the ferritin, this was also increased. The level of D-dimer was not very much increased, but yes, it was somewhat increased. We know that the D-dimer level should be less than 0.5, basically. So these all three parameters were increased in the patient, but CRP levels were normal. The CRP levels were normal, right? Now we were in a dilemma. The patient was maintaining saturation without oxygen at 93-94%. The patient's 6-minute walk test was normal. The patient had no other complaint, no chest pain, no respiratory discomfort, nothing was there. But these blood parameters were there. Now, as per these blood parameters, should I discharge the patient or no? So what we did, we just tried to find out certain literatures, and with the help of certain, colleagues and other experts, I just came to know that there was a literature also which was published in the Journal of Immunity and Aging. It was a journal, and they simply said that when you are discharging the patient, in most of the patient, what you will find that the CRP level has come to normal and the leukocyte count, these are increased, and these basically suggest what? The ferritin level and all these suggest what? The D-dimer ferritin level, these suggest what? These only suggest that the fibrin is degrading. The clots which are already formed, the fibrin degradation, they are basically increasing. So they just signify fibrin degradation products, that's all. But if you have a patient who is having a normal CRP and who is maintaining all the clinical criteria, as maintaining oxygen, no temperature, he is a valid candidate to get discharged. So I always say practically that please do not believe on the ferritin or the dimer levels much, but obviously they are increased in the significantly higher level or in complicated level. Obviously we have to think about that. But yes, slight increase in the range like 400 ferritin, 500 ferritin, it is not that significant. Okay, now when you say about, I'll tell you one very, very interesting thing about D-dimer. This D-dimer, we all know that it is for the clotting factors, and the level, when you talk about the D-dimer level, the D-dimer level is less than usually 0.5, which is normal. Okay, and this D dimer, if I'm not wrong, D dimer levels are basically given in two kind of denotions. Either you can say that, either you can say in the nanogram. So in nanogram, you say they are less than 5 nanogram per deciliter, or in the other values, if you say they will be basically in the microgram, they will be less than 0.5 microgram per deciliter, like that. So just multiply it by 1000 and it will be like the same. Now, when you talk of these levels, D dimer levels, certain people in their normal situation can have increase in the D dimers. And what are those people who can have increase in D dimers? See, the D dimers can be very significantly increased in the patients of those who are having chronic inflammations, right? These can be normally increased, or normally you cannot say normally, other than COVID, other than COVID also, these marker, the COVID, the D dimer can be increased. Other than COVID, where it is increased, they can be increased in patients who are in pregnancy state, the females. They can be increased in pregnancy. So D dimer can be a increase when the patient is in pregnancy. These can be raised post trauma, road traffic accident. These can be raised if the patient is having the carcinomas, obesities. When the patient is a chronic smoker, these are conditions, or he's having some other kind of inflammation. So these are also the condition when the D dimer can be raised. Or also one important thing that you should always remember, which I realized in last couple of months, that D dimer can be the actual limit every age. Values, they hold true till the age of 50. Till age of 50 coagulable state, correct. Till the age of 50 we follow this criteria. After age of 50, what we have to follow? After age of 50, the D dimer level of patient, we just multiply it by 10. Age of patient into 10. So if the age of patient is 60, it will be 600 nanogram per deciliter. And what will be the abnormal value? Abnormal value will be approximately 1.5 to 2 times high. That means more than 1200. It's like that. So approximately 1000 to 1400 nanogram per deciliter. That is one thing you should remember about D dimers. Now, somebody has asked me, can ferritin decrease? Yes, ferritin can very well decrease with anemia basically, right? It's a hemoglobin when the patient is starting getting some infection, patient is getting anemia increased. So this is a broad thing. So all in all, as a practical point of view, I can tell you, but levels of ferritin, levels of interleukins, levels of D dimer are slightly high, and we are often worried that in my father, in my mother, in my relative, in my somebody known to, the levels are slightly high. Patient is otherwise fine, but the levels are slightly high. So just believe on CRP report, that if CRP, if the tissue, in short, I just wanted to discuss with you about the investigation part. When you talk about the treatment part, let me tell you the thing I want to discuss. See, we have been seeing, as a team, I have been seeing that as a part.
आपके पास जाएंगे कि मतलब रिक्वेस्ट
पता नहीं, मेरे यहाँ पे तो दिखा रहा है यार ऑन है.